everyone. Welcome to our Everything Parkinson's webinar. Thank you for being here today and spending the noon hour with us. I hope you will always consider watching our videos. For those of you who are new, we do have a robust collection of videos in our website. You can go back at the Pacific Neuroscience Institute webinars where there are a lot of topics with regards to Parkinson's, everything from gut health, diet, exercise, speech therapy, etc., updates on newer medications. We have all that in our previous webinars, so you can certainly watch those older videos in our website. But here today, we have a very special guest, always a treat for us to have her. She is certainly a very familiar face on our Everything Parkinson's webinar. For those of you who have previously or are regulars in watching our webinar, you've seen Sheila before. Sheila Moore is our she's a licensed social worker, but she is also a very special part of our team because she is also our liaison with the American Parkinson's Disease Association. As you know, she works closely with us and our Parkinson's patients here at the Pacific Neuroscience Institute. So it's a very interesting topic today, and we veered a little bit from the usual topics of, the medical side, medications and treatments, and talk a little bit more on what is out there, what are the right um support that you can have or resources that you can have in your in the community that will be helpful in the different stages of the Parkinson's. So without further ado, please welcome on our Everything Parkinson's webinar, Sheila Moore.
Oh, thanks, Giselle. Thank you so much. It's a pleasure to be here with you this afternoon. I guess we're starting in the noon hour, and I certainly appreciate sharing this time with you and appreciate the opportunity to talk about an important topic, planning with care, choosing the right support at every stage. I have to say that I appreciate doing the webinar, and the hardest thing for me is that I can't see you because I'd like to be able to see each and every one of you. I'm sure that there are people that I know who are here, and maybe some people who are new, and yeah, it's a hard part, especially topics like this where I want to spend some time with you, and not necessarily just talking, just sharing information. But that's what we're going to do today. I'm going to be sharing some information on really the continuum of care. What services are available? What things do you want to think about? Maybe I'd like to spend some of the time talking about both the practical and the emotional, and I'll get to that in a minute. But I do want to say that it is a pleasure to be on the Pacific Movement Disorders team at the Pacific Neuroscience Institute. I'll be celebrating my 6th year here this year. Very pleased. One of the highlights really of my job is to be having a close relationship, not only with the American Parkinson's Disease Association, with my colleagues in the leadership at the Pacific Movement Disorder Center, but with each and every one of you, with the Parkinson's community. Really a special and powerful community, and I'm really pleased, and it's a great honor to be here and to be of service to each and every one of you and to the community itself. So let's dive in and let's get started. I want to welcome you all here. I really think it takes courage to be here today. Thinking about care options is not easy. In fact, many people too often wait for the crisis to help them make these kinds of decisions, whether it's a healthcare crisis, a financial crisis, something else that comes out external to self that might move us in one direction or another. And I think that comes down to kind of a complexity of issues, but really none of us like change. And I think from the beginning, when someone's been given given a diagnosis of Parkinson's disease, it sets you on a journey and pathways. And I'll talk a little bit about my graphic, the picture here sets on a pathway that can be really complex and difficult right from the very start. And it's really a hard process, and particularly when we're talking about care, choosing care, and making these kinds of decisions. So I think it's really a hard process. It involves what I think both practical and emotional. So I often use this slide here to talk about, I usually break it down to those living with Parkinson's disease and care partners as these parallel roads. Once a diagnosis is given, the person who's living with Parkinson's disease has their journey. The care partner or caregiver has their journey as well. And there's a period of time when things are parallel and then things start to change. And I think it's true with this process, with this decision-making process, thinking about care, thinking about need, thinking about how ways to meet that need as it changes over time. There's a practical part and an emotional part, and they kind of run parallel. And I think sometimes the complexity comes when the practical and the emotional start overlapping. Sometimes it can propel you forward. Sometimes it can be paralyzing. And so I want to talk a little bit about that. I do want to talk about both parts, the practical and the emotional. And I promise you we'll get to talking about the different places, different kinds of care, both in home and out of home. So the practical parts of planning and decision making, I think, involve all the to-dos that are present for both those who are living with Parkinson's disease and for care partners. There's lots of things to do in the day, things that are distracting. Needs may come up, they may get addressed, and then you move forward. But there's a lot of things that are distracting over the course of the day and over the course of your caring and the things that you might need. There's a lot of changes related to Parkinson's disease, that can shift and change. It really is a moving target. What do I need? What do we need at this particular time? My experience of working with people who have Parkinson's disease is mornings can be one way, afternoons can be another, evenings can be quite another. This week can be one way, next week can be a real challenge. The following week, things seem to be resolved and back to baseline. Like it really is a moving target. And this moving target happens throughout, I think, the phases and stages of Parkinson's disease. Um, my experience has been there's both a physical and a cognitive changes. So there may be physical needs that require one kind of help, and sometimes there's cognitive changes that require a different kind of help. And sometimes these both merge so that there may be both physical and cognitive changes with needs that come from both of those challenges, that really need to be addressed and that can make planning and decision making hard. I also want to honor that this is more in a series of adaptations and changes, right, with Parkinson's disease. From the very beginning, I see people making all kinds of adaptations, from putting more time and effort into thinking, getting from one place to another, using things like that support you, like canes and walkers. And then for the care partners as well, which is really important, we'll talk about that too. Like, where's the stress points? Where do you need help? So it's more in a series of adaptations, both for the person living with Parkinson's disease and for care partners. And then I think another practical part of this, which is really important, we'll be talking about this, are the resources, both the financial resources and the emotional resources. And I think particularly with the emotional resources, it definitely can be those living with Parkinson's disease, the stressors, the tensions. Moving is not the same. Maybe even thinking through things, memory is not the same, and that's hard, and that's certainly part of your resource bank. And also for care partners, the emotional toll can be really, really high. And so it's important to think of your emotional reserves as a resource as well. And so we'll talk a little bit about that next. So there's this, and we talked about the practical part, this practical part of the journey of planning and decision making, and the emotional part is equally important. You know, it's that other pathway. And so if you're experiencing stress, both those of you who are living with PD and care partners who are listening in, experiencing anxiety, fear, feeling overwhelmed, maybe anger, resentments, being paralyzed, wanting to avoid even thinking about this need, and finding ways to address those needs, you're not alone. That's the emotional part. This is the reserve that I was talking about. So if you're experiencing any or all of these things, that's, I think, a normal reaction to the seriousness of the changes, of things that you're seeing, of the ways that you want to make sure that if you're living with Parkinson's disease, that you get through your day safely, holding on to the personal reserve, and for care partners as well, getting through your day, holding on and honoring your personal reserve, the resources, the personal resources. In the same way that we want to be, in terms of our finances, like fiscally responsible, good stewards of our finances, the same way emotionally for both those living with Parkinson's disease and care partners. We want to be really good stewards. We're going to address this as I go along, but I do want to I just want to kind of call it out before we move forward. So the goal of this hour is to really to introduce the options for care. We're going to discuss these options on a continuum. Mike, the continuum is, it could be like at the very beginning and at the end stages of PD. It could be the continuum of in-home care to out-of-home care. So it's these different continuums. And I'm really hoping, and I think we as a team are really hoping, that discussions like this, webinars like this, will inspire some thinking, thoughts, and I'm really hoping conversations. It could be between the person living with Parkinson's disease and care partners. It might be between care partners and healthcare teams, those living with Parkinson's, care partners, and family members, really inspiring thought and conversation. So ultimately, what we want to do today is to offer information to both empower and support you. So during this hour, I'm really hoping that you'll listen with an open mind, that if there's any anxieties or fears that might come up, I hope that you're gentle and kind with yourself. So if you've made tea or have a cup of coffee or want to go and get a glass of water so that you can sustain yourself, as things might come up or might not. You might be just hungry for the information. We'll talk about that in a minute. Maybe just starting. So I just want to just kind of honor where you're coming from, your nervous system, and from what might be happening. Remember that you're not alone, that your team at the Movement Disorder Center, certainly at the American Parkinson's Disease Association, and the community stands with you. And I'm going to make this PowerPoint available to any of you who would like to see it. So if you want to write notes, great. If you'd like to just pay attention, this is also, as Giselle said, will be taped and put on our YouTube channel, so and the website, so you'll have it available there. So just kind of during this hour, just ways to take care of yourself, because I know that some of these things are tense. It's hard to talk about sometimes, and I just want to honor that. So, and please, let's all remember that for some this may be a starting point, and for others this may be next steps. Dr. Petrosian says, when you see one person with Parkinson's disease, you see one person with Parkinson's disease. And I think so it's true in the planning and the choices that you'll be making, that one size does not fit all. So I'm going to talk to you about a variety of different options, and some might fit, some might not fit, some things might be way down the line for you. Some things might be very timely and important, but it's not a one size fits all. And so these are very broad strokes. I promise you, I can't be as thorough as I want to be. And I could definitely talk about these things from the person living with Parkinson's disease. We could have a webinar just on what I'm about to talk about from your perspective, and another webinar just from care partners' perspective. So I'm going to do this very broad stroke with the idea that this is be an introduction and a starting point. So with that said, this is a start, this is a beginning, and we're all here together. You're not alone. So today we're going to talk about home care options, from home care to skilled care. Maybe some ideas about what to think about as you plan, from identifying needs, providing care, talking about finances, special considerations for care partners and caregivers, because you factor in here in a very important and a very important way, and finding support along the way for both of you. So I wanted to talk a little bit about activities of day. Sorry, it's kind of a rough transition, but before we start talking about the different kinds of care, I think it's really important to talk about activities of daily living and instrumental activities of daily living, affectionately termed within most professional circles as ADLs and IADLs. And I want to talk about this, and we'll talk about why it matters. But because oftentimes those of us from a professional perspective will be looking and making assessments, getting information to help guide you based on these basic tasks and these more complex tasks. So I wanted to give you an idea of what from medical professionals, like rehab specialists, social workers, even places that you might go visit, agencies that you might be working, what they're going to be using as this becomes a very standard ideas of how people are doing or kind of a guide. So the ADLs, these basic tasks of daily living, are like bathing, dressing, toileting, transferring, continence, feeding oneself. These are the basic tasks that someone engages in on a daily basis to get through their day. If someone has chronic health issues like Parkinson's or memory changes, these basic tasks can start changing. Someone might need more help. So if someone is struggling with one or more of these tasks, they may need more care. And sometimes if you're wondering about it, sometimes I talk to care partners, for example, or those living with Parkinson's disease, they say, "Yeah, I really don't know." Like these would be a good guides to be able to help you. Am I having trouble bathing, getting in and out of the shower? Well, I have those bars. Do I maybe having someone to support me or someone that I can help me support my husband or my wife? Would that be helpful? These are kind of the basic tasks and how we look at these things. These are kind of a language, so to speak, that we all can share together and use as a guide to determine need and then matching what kind of care might address those needs. The other one is the IADLs, or the instrumental activities of daily living. These are more complex tasks, and as you see in the italics, changes with IADLs usually show up earlier than the changes with ADLs or the basic tasks, and could mean more help is needed, but at a different level. Maybe more cognitive changes are going on. Someone can't do their banking, can't do a checkbook or getting online and reconciling bank statements. Handling transportation, maybe driving has changed. Maybe public transportation isn't an option, so transportation has changed. And it goes on, shopping, meal prep, housekeeping, managing medications, using communication devices like telephone, emailing, texting's becoming hard. These are the kinds of things that we all look at to see how is a person doing in terms of living independently. And I want to be very clear that it's not about ways that we're identifying that you can't, but it's ways that we use to identify what kind of supports do you need to live as independently as you possibly can with the way I frame it, the highest quality. And sometimes when we try to do that independently, kind of steamroll through things, we end up sacrificing so much in terms of stress, maybe falls, maybe just feeling tension and uneasiness and fear. But if we're able to come together, identify some of these issues, whether it's IADLs or ADLs, we identify the need and match that need with conscious care, thought out care and supports. One can live independently and have sorry, live independently and get the kind of support that they need. Sorry, I thought I heard someone at my door, but sorry about that. So we'll just one more slide and then we'll move on. So why ADLs and IADLs matter. And I think I talked a little bit about that healthcare providers use ADLs and IADLs to make assessments for the care someone might need, that insurance programs like Medicare, Medicaid, it's Medi-Cal here in California, VA benefits, long-term care insurance organizations require documentation of ADLs and IADLs in terms of their limitations for coverage or what they'll cover and when those kinds of coverages will spring into action. So again, this is this kind of almost like this universal assessment a universal assessment tool that I think it's really important if you don't know already to become familiar with it. And I certainly I'm happy to help you and talk you through some of these things. Um, and you yourself can use this as you plan, and you can use it as a guide. So when someone says, what kind of help do you might, like a social work type might say, would you have any special needs or do you have any needs? And you might say, no, I don't. But if you look closely at it, you might identify some things that might be helpful. And it doesn't have to mean being cared for outside of the home. We're not jumping there. We're finding again, right? The frame is what can we do to support? What services, what things can we bring in to be of help? And and we can use the ADLs and IADLs as guides. And oftentimes I will get people who come to me and say, when will I know that it's time to hire someone? When will I know it's time to maybe be thinking about a place that my spouse and I can age in place together, or that maybe care outside the home is the better choice than being home? And I usually say to care partners or those living with Parkinson's disease, that it's likely that when this question formulates for you, you've been seeing things that maybe raise some concern, or things are harder than they once were things. And I say, this is why I say that you intuitively know. And I think that if you were to look at the IADLs and the ADLs, you could see where there might be things that just weren't, that have changed, and that it might mean that some change needs to happen in support of you living as independently and safely as possible. So let's talk about care plans. Let's talk about care outside, care options, care in the home and care outside the home. And that's where we're going to be focusing on. So in-care options include informal home care, which is family and friends, usually the very beginnings. Non-medical care or supports, usually the next level of care, that there's more care, maybe care that you would purchase and bring in from agencies. We'll talk about that. There's home health care, which can be a support like we're talking about. And then there's palliative and hospice care. And these are all in-home care options. So informal care, for example, who is it for? It's usually for people who are challenged with getting through their days independently. We talked about the ADLs and IADLs, like there's been some changes that's making it harder to get through one's day. And what's provided, usually it's companionship, help with meals, errands, reminders, safety oversight, like making sure that maybe like things are there's safe paths for someone who's living with Parkinson's disease. The benefit is that this is at-home assistance, and the cost is usually minimally financially because this informal care is usually provided by care partners who over time might go from being a care partner to a caregiver. But at the very beginnings is the one who's, or it could be care partner, it could be a friend, it could be an adult, a daughter or son, it could be, but it's an informal network. And the cost is minimal, but the financially, what we talked about, right? The financial costs, but the resource costs usually rests in terms of the care partner and the caregiver who over time might experience burnout, who, as these changes are happening and they're providing this informal care, that we need to really be very mindful and think about them here too, in terms of their own resources, in how this is affecting them. What's the cost? And that's an important cost to factor in. But informal care can work for a very, very long time. And often does for many families. That's usually the first choice. And we don't even, people don't even think about that necessarily as a choice or option, but that is care. That's the first level of care. Secondly, we're talking about non-medical home care. So that's usually when someone is hiring someone to come in to be of assistance. So who's it for? It's for those who need more help with ADLs and IADLs. And I should have put down that maybe it's becoming more taxing for care partners, and the needs are getting more. The changes in the IADLs and ADLs are becoming more pronounced and very obvious. So what's provided? Usually someone will come in with, and they might assist with bathing and dressing, although not always. That might not be the issue that brings someone in. It might be that there's more mobility issues. So transferring chair to standing, chair to bed, for example, or any kind of assistance with mobility. Maybe it's supervision. Maybe there's light housekeeping, maybe medication reminders and assistance. And really what's important here, and we've talked about this, is that respite for care partners or caregivers. Generally, what I say to those who have Parkinson's disease and for care partners, I usually say you want to think about all the tasks that you're doing that are really depleting that reserve of getting through the day. So if having someone come in who can do laundry, who can do dishes, who can make a meal, who can help take you someplace and can help you preserve those resources that help you get through your day independently, get through your day with high quality, then that's the time to think about having someone to come in. And non-medical home care is someone who comes in who's paid to help do those things. It's an assistant, someone who can make up the difference between what you're seeing or the changes and where you'd like to be. So usually the providers are agencies. There are informal networks. So even within the Parkinson's community, if you're out there doing ping pong for good or boxing or dancing through Parkinson's and you have a community and you see someone has someone who's helpful, sometimes people will go and say, oh, do you know of it? To ask the person, do you know of anyone? Do you have? And there's this informal network. There are pros and cons to that, but that certainly is an option. A lot of people will also turn to agencies for help, someone that you hire who comes in and provides help. And certainly for those who meet criteria for in-home supportive services through Medi-Cal, that's also another service. You do have to meet very specific requirements and eligibility criteria for Medi-Cal. And I will not be going into that today, but I certainly, one-on-one with any of you who would like to, we can sit down and have conversations about what those options are like. Usually there's minimum hours that people will come in for. So sometimes even informal network people will say, I have availability, but in order, I'm looking for 6 hours a day or I'm looking for a couple days. Sometimes people don't have that criteria. Usually agencies, at least particularly now in this kind of a climate, will be looking for like they might say, we can send somebody out to your home, but we have a minimum of 6 hours a day or 8 hours a day or so many days per week. So there's not quite the same flexibility. Oftentimes I hear people say, oh, I just need 2 half days a week. That's really all that I need. And sometimes it might be a little bit harder, tougher to match that, but I think it's doable. But just so that you know, that's an important part. Like sometimes there's criteria in terms of agencies and more formal care. And the cost right now in terms of these agencies and the private and it's usually private pay, is $35 to $40 an hour. And for IHSS, there's no cost if eligible, but again, you have to meet this eligibility, which is through the Department of Social Services. We'll talk a little bit about that in terms of places that you can go to find that information out. And that's that. I'm just going to go back for a second. So that non-medical home care can usually, if you can purchase those services, you have the financial resources, can really get you a long way in terms of being cared for at home and staying at home for a really long time. A lot of people make that happen. And so that goes from like family providing care to non-medical care. And it doesn't have to be a lot. I mean, everybody's going to have these different needs, but those are options. This next option is home health care, and this is really for what I would consider skilled or acute care. And I'll talk about notes and some of the caveats. But home health care is who's it for? It's for those who have skilled nursing needs or those who are homebound and need benefits from rehab services. So what's provided is usually like a visiting nurse will come out, do assessments, monitor, help with medication assistance. Usually when we see home health care, and many of you may have already had that benefit, It's a Medicare benefit that, if you've fallen and hurt yourself and you've gone to the hospital and you come out of the hospital, the doctor will send health care out and a nurse will come out, assess how you're doing. People who have diabetes, people who need maybe wound management, those kinds of things rely on home health care, someone to come in and double check. People who have Parkinson's disease can rely on home health care too, as well. This is usually when someone's homebound, they can't get out, and they need to have these kinds or benefit from these kinds of services, physical therapy, occupational speech therapy. That's something that you would talk to, like your your movement disorder specialists like Giselle and Dr. Petrosian, and talk to them about things that you might need. Your primary care doctor could also write a prescription, make a referral, and that kind of care would be provided. It's really important to note that this is for short-term after hospital discharge or for homebound need. It's not meant to go ongoing. So you're looking more at informal, this non-medical care. That's for long term, but home health care can really help and be super helpful and supportive when your needs change. So it's short term, it's covered by Medicare with a doctor's orders or private insurance, and it's for acute care needs, not long-term needs, right? So there's going to be definitely a beginning, a middle, and an end to these kinds of services, but it's something that if you are unable to get out of the house, that's available to you, or if something acute comes up, that this is something that's available that you can, these are kinds of services that you can have at home. And another kind of care at home is palliative or hospice care. And who it's for is for those at the end stages of chronic health issues like Parkinson's disease or those with multiple health issues. When decisions have been made that we're talking about comfort and quality of life versus aggressive treatments. And what's provided is pain and symptom management, comfort-focused care, and support for family. These services are covered by Medicare, Medi-Cal, and most private insurances. So someone, it's if there are financial resources, and we'll talk a little bit about that as we go on, that someone could stay at home throughout most of the care as their care changes, they can stay at home. It's not necessarily that someone inevitably will be cared for outside of the home, but there's lots that can be done inside of the home. These are options. And it's important to know, just kind of again in these broad strokes, what your options are. So some of the pros and cons of care at home is that most of us want to stay at home as long as possible. We all understand that. It's familiar, it's comfortable, it's home. I don't even need to say anything more than that. And that's like the most important thing, really. But what happens when someone has chronic health issues, particularly those that are progressive in nature, is that sometimes the needs really become more complex. And the resources, when we're thinking about this, really need to be considered, both in terms of finances. Is this something from our financial perspective we can do, we can cover this? Are these really nuts that we can crack? And then besides the financial piece is for the care partner, which becomes a very essential part to think about in terms of the resources. What resources do the care partners have? How are they doing? Because like I said at the beginning, a lot of time care at home is provided for a very long time informally by care partners, and they matter. So we want to think about that too. This is a marathon for both those living with Parkinson's disease and care partners. We want to make sure that we provide support in both directions. Sometimes receiving care at home can be complicated by both memory, cognitive changes, and the physical changes. I think it's one of the hardest things associated with Parkinson's disease, that there's physical changes and there can be cognitive changes, which makes things complex and sometimes make caring for someone at home or receiving care at home hard. Hard because of the resources, hard because of the kinds of supports that need to be brought in, and because some of the complexities of care, which can require 24-hour supervision, someone there 24 hours to be of help and assistance. And for care partners, the stress can really be an overload. It can be something we call, there's a book that's written primarily for those caring for someone with Alzheimer's disease. But I think with PD, it also can fit because it's both it can be, not always, cognitive and physical, and it can be really a 36-hour day. Your time gets spent 24 and you're always looking for that next 12, because it's really required. So it's something to think about. And sometimes care outside the home can be really, it can be very supportive because it can provide structure and socialization and lots of different kinds of perks and supports. So it's important to think about both the pros and the cons to being at home. I know a lot of people choose to stay home. I mean, it totally makes sense. And we all of us on the team really want to support that. And we also want to be frank if we think that a different level of care might be something that's supportive to both those living with Parkinson's disease and care partners. So we're going to start moving away from in-home care and talk about residential support or care outside the home. And again, I'm going to do this as a continuum. I'm going to talk about independent living, assisted living, residential care facilities or communities, memory care, and skilled nursing care. So with independent living, who's it for? It's generally for active seniors who can live independently but want a community setting. And it's not unusual for people who've been recently diagnosed to live in independent living communities. It is because it's basically independent living. And oftentimes people who are recently diagnosed, that's an option, right? What kinds of things are provided? Most independent living communities include housekeeping, meals, transportation, and engagement programming. What's not provided is there's really no medical or personal care services. The services can be added, but it's not something necessarily that someone comes in looking. They're coming in to look for support in those kind of resources we talked about it, things that might be you don't want to kind of spend your resources on, like someone who can cook and clean and be there and take care of laundry or to help us with the engagement, maybe even transportation. And it doesn't tax you like maybe living at home independently would. And I say a gray area because one can choose to live in independent living communities. And that doesn't necessarily mean that you will need to move to an assisted living facility for quite some time. Usually whether we're talking about independent, assisted living, kind of communities, you can enter at a specific level, and you can add or purchase services as your needs present themselves. So you can purchase more care. So it's not like you have to be moving, 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 moving. And sometimes independent living has assisted living facilities, has memory care facilities. So you can absolutely, and we'll talk a little bit about that, you can age in place, right? As your needs, your community where you live can match and meet those. Sometimes independent living, you can purchase services. It could become like an assisted living, right? So there's all different kinds of ways. That's why that one size fits all, like there's so many things. There are so many options and choices that you have that I just appreciate the opportunity to be able to tell you what's out there and what's available and ways that you can think about these things. Usually independent living communities, the environment is like an apartment or a cottage style living with community dining, fitness rooms, events. It's a place for supportive living, to be living independently, or purchase services as your needs change. It's not licensed as a healthcare facility, so there's no licensure. It's really just kind of sometimes it's apartment living. Sometimes it might have small kitchenettes, but it's not licensed as a healthcare facility. Usually the costs, and these are all, I mean, I did some research, but I know these numbers could be low. Let's just say a ballpark is like between, let's say, $4,500 to $10,000 a month. Sometimes there's a lot of sticker shock. Healthcare is really, and caring outside the home can be quite costly. But sometimes it's important to know what the range is and then do some exploring and looking at what's available out in the community. Usually these services or this kind of living is private pay. It's not covered by Medicare or Medi-Cal or any long-term care insurance. And this was I have a note here about that continuum of care. There are continuing care retirement communities or CCRCs where one has the opportunity to age in place. It's certainly not for everyone. The price points can be pretty high, but for those of you who have these resources, it's something to consider and think about. Some communities have different levels of care that are not on the full continuum. So like I was saying, like you could enter an independent living, you could purchase services. Sometimes they have people who will come in and help, just like at home, that they have available at these communities. Sometimes you can purchase services external to the community. Like you can really make sure that your needs are met for a for a length of time. If you do your research and pick wisely in terms of maybe even independent or assisted living. And let's talk a little bit about assisted living. So assisted living communities are for those who need help with the activities of daily living, both ADLs like bathing, dressing, and taking medication, and those who might be experiencing more memory changes. And when I talk about memory changes, it can be short-term memory. It can also be, we talk about some changes with executive functioning, and also it's in terms of judgment, which can make living at home or living in a lower level of care harder. So assisted living is set up to provide that kinds of support. So the kinds of services that are provided are personal care assistants. They might have their staff who are available 24/7 to have assist as needed, 24 hours a day. Usually there's meals, housekeeping, transportation. There's social and wellness programs for people who live in assisted living communities and medication management. What's not provided is there's no medical care. Again, this is not a skilled level. This is providing supports for you and the person that you're caring for to live as, I'm saying independently, but having supports, one can live independently. So buying and purchasing, having the support there to get through their day without having to go to skilled level. So it provides that kind, but it's not medical care. The environment is there's often private or shared rooms. And the environment is might be apartment units with limited kitchen amenities. So there might be a microwave, a small kitchenette, a bedroom. Sometimes there's a living room. It can be something like that, or it can be a room where someone has, and we'll talk about a smaller assisted living or board and care facilities or communities in a minute, but places like that that have amenities. So assisted living, this is important. So we go from independent living, home, independent living into assisted living. And then there's a different way that the community and the healthcare community and the public healthcare community start looking at providing care. So it starts getting edging more towards healthcare, but not medical care. So assisted living facilities are licensed by the California Department of Social Services, and they're licensed as residential care facilities for the elderly, or RCFEs. And so that's I'll talk about that in a minute. So there's a licensing component, and you can ask about that if you're inquiring around. You'll want to see and make sure that these places are licensed. It's another way of looking. It's another way of making sure that that the kind of care is meeting healthcare standards, all the standards that like all of us who provide healthcare, there are standards, policies, things that we have to adhere to make sure that we're providing the highest quality and highest level of consistent care, right? So the cost can be anywhere from $400 to $7,500 a month. The higher ends are $8,000 to $10,000 a month. You can add memory care services often in assisted living for additional cost. I wouldn't trust my numbers. These are just ideas. And when I did research, but this just gives you an idea that the cost will move as you purchase more services. And I hate to be talk like this, but that's that. But I want to be frank. So you purchase more services as need changes, and the cost will change. But someone can stay. It's not necessarily that one moves from assisted living to memory care. Sometimes that's true. Sometimes assisted living can become memory care by providing more services. So what's assisted living communities? How are they paid for? Usually by private pay. Lots of times this is when long-term care insurance can come in. If you've purchased long-term care insurance policies, this is where they would start kicking in and helping in terms of those kinds of services. Some may qualify for assisted living waiver. And the only reason I'm bringing this up is because I want to be thorough. But the assisted living, we'll talk about that in a minute. The assisted living waiver is for those who are on Medi-Cal and who meet criteria. Currently, in the state of California, this is something that the state did in order to provide support to those who have um, skilled needs, but may not fit in a skilled level community or skilled level facility. So it's the idea of saving the cost of skilled nursing through these waivers. So people still live in community, right? It has exploded. I was just looking at the numbers. Right now in the state of California, it looks like there's over 15,000 people who are serviced by this assisted living waiver program, right? People also are on the waiting list, and it's like 11,000 people who are on the waiting list. And I say that and it sounds daunting and stark because of the need, but I just want to let you know that it's available and out there. I mean, it's out there just so that you know that that's something. It's a long waiting list, but it might be something that might be worth like exploring and getting on that waiting list because I mean, we really don't know how things move, and things might change over time. It's hard with our current landscape, but it's just something that I wouldn't want you to start. What's this assisted living waiver? And Sheila didn't mention it, but this is the assisted living waiver. I think I was reading that it's going on for several more years, but it's just something to know, just to have that information. Assisted living is not covered by Medicare, and so the burden of the finances are often private pay, those who have long-term care insurance, and also for those who might be eligible for the assisted living waiver program. It's covered. So the third level of care or the option for care is through the residential care facilities. These are the board and care homes that people talk about. And who is this for? This is for those who need non-medical assistance in more home-like setting. It's for those who have memory changes or dementia and they have higher care needs than standard assisted living. And what's provided is it's a small home-like setting. It's usually 6 to 8 residents. It's more personalized, and the care includes more assistance with mobility issues and supervision for people who have significant memory changes. The environment is a smaller, more intimate setting, and most of these are small converted homes. So some of you might be in neighborhoods where there might be a residential care facility or a board and care facility in the neighborhood where they've converted homes where people stay, they have meals, they have care, they have socialization, structure, and it really can be a really wonderful option. It's not like a large assisted living facility or even a medium. It's really meant for small, very intimate kind of care, and can be an option. So I know a lot of times people are thinking about independent, assisted living. We all have our ideas about what assisted living. I will really caution you to put some of your old ideas aside until you kind of consider it, do some research, and then start getting out there and seeing what's available. Because sometimes these are really good options. Certainly not home, but they can be really good options. So I just want to say that. And the residential care facilities or these smaller board and cares are really they can be a really lovely option for those who need that kind of support. Maybe those who are caring for themselves, for care partners who need a break and respite. There's all different kinds of ways that we can look at this in terms of how these can be supportive to you. This is licensed by the California Department of Social Services. So these residential care facilities are absolutely, they're licensed, and they have very strict criteria, and they are assessed often annually, and they're relicensed. And so you get proper and good care in some of these this is a smaller care option. The cost can be $4,500 to $7,500 a month. And sometimes for more intense care, like for memory care, if that's added in, it can be even higher cost. These can be covered by private pay and again, the Medi-Cal assisted living waiver program. Although again, that's kind of my kind of a placeholder, but it's just something to know about. And then often, and then Medicare, sorry, then memory care. And this can be oftentimes within assisted living residences. So it would not be unusual to explore assisted living residences, communities, and they might have a memory care unit on the premises where someone, if as their needs change, particularly if there's dementia or some significant memory changes, that this would be an option. So who is this for? These are for folks who have significant memory changes like dementia. And what's provided is an enhanced supervision and a secure environment. People specialize, there's specialized activities for cognitive support, care with activities of daily living, special care and supervision for those who may have memory changes, need reassurance and redirection, specialized activities and a secure environment, which becomes really I think really the key and the hallmark here. It's licensed by the California Department of Social Services. The cost, there's usually an additional cost if you're moving from assisted living community to a memory care unit. And we've talked a little bit about that. And it's usually covered by private pay or long-term care insurance. So those are the options in terms of memory care. And then kind of on the far, so we're talking about living completely at home with care, all the way to skilled nursing care. And oftentimes skilled nursing care, it may not need to be an option. It doesn't have to be, but it's available for those who might need it. So who is skilled nursing for? It's for individuals who require 24/7 medical care, those who require rehab services. So oftentimes people who have hip replacements, they themselves may be going to a rehab facility. And within these rehab, which is a short-term stay, there may be long-term care as well. It's 24/7 licensed nursing care. There's physical, occupational, and speech therapies available. There's medication administration and monitoring. So so all the activities of daily living can be assisted at skilled nursing. The environment is more hospital-like. Or long-term care facilities with licensed nurses and medical oversight. So there usually is a director of nursing. It's kind of hospital-like director of nursing. There's usually a medical director. Physicians come in and are making visits to skilled nursing facilities or licensed by the Department of Public Health and are usually accredited through the Joint Commission. So it's just like a hospital setting. The standards are high because we want the standards to be high for those who need this kind of care, right? The cost for a shared room is 8 to 11,000 a month. Again, these are ballpark. And again, forgive my research if it's a miss. And then private rooms can be anywhere from 10 to 13,000 a month. It's usually covered by Medicare, may cover short-term rehab stays up to 100 days. Long-term stays may be covered by Medi-Cal if eligible. And this is a different kind of Medi-Cal. This is long-term care Medi-Cal. And I'll talk about that in a minute. But mostly it can be paid by private pay or long-term care insurance for those who do not meet criteria for Medi-Cal. And again, this is the long-term care Medi-Cal. So I do want to just say that from skilled nursing facilities, I know that there's a lot of concern. Sometimes it's wondering about oversight. So I did talk to you about how it's licensed through Joint Commission, but also the Ombudsman Program is another state entity that oversees the care for people who are receiving care at skilled nursing. Then I put elder law attorney. And I'll talk about that in a minute. But seeking an elder law attorney, particularly if you do not have Medi-Cal now, but are thinking that long-term care might be an issue, seeking assistance from an elder law attorney can be really, really helpful because they can talk to you about eligibility both now and in the future. So I really feel like an elder law attorney, when you're talking about options for care outside the home, particularly, or even care in the home when you're thinking about these things, would be a good person to consult with about how am I going to finance these options? And particularly because of the long-term care Medi-Cal, which is what most people rely on when it's that level of care, to pay for those kinds of services at this level of care. So we've talked the continuum of independent to skilled nursing, to providing most needs for someone who's in a skilled nursing facility. We've talked about the continuum of care out of home, in home, and out of home. All the as needs might change over time. And so I entitled this Field Notes just because I like to give you some tips and things that I've learned over my time working with care partners and those who have chronic health issues. So just things to think about when you're thinking about either care at home or care outside of the home, that sometimes there can be a lot of tension about like what is right now and worrying about what might be next. So I just want to say that care is a moving target. Someone's needs can be a moving target. So it's hard to hit the marks as things change. So if you're feeling like one day you think you might need this, another day you might need that, it's because things are changed and things are fluid. And what are the needs now and what might be next? It might be really hard, but the best thing, hard to predict, but the best thing you can do is to consult your medical team, consult those of us who are community-based who can give you an idea, and just think about what might be needed now and maybe what might be the next step. And what I want to say is that change could be likely, right? The needs might change, and also the way that care is delivered could change. So sometimes there's a mindset of this is how it is, and this is going to be the right kind of care. But you can see that you maybe go into independent living and then you purchase services, assisted living, you purchase services. So there can be more fluidity in the community and the kinds of care that's out there. When thinking about what is needed, for example, again, this moving target, I wouldn't think of what the best day is, because sometimes we do that. Like we think about what's our best, like you think about what do I need? And you think about the days when are the best days. Well, he really isn't that bad, or she isn't that bad, or I had a really good day. But I would really encourage you to think of the day that was hardest over the last week or two. What kinds of things would have you found helpful on that hardest of days, and think about the kind of care, if you're thinking about that, if you ask me, that's the target. That's that bad day that you had. That's when you're needing care. Maybe not in the good days, because it does fluctuate. It is a moving target, in my perspective. I also want to say that knowledge is power and having support is a superpower, right? So you want to gather information, ask questions of your care team, the social workers, the fellows in your Parkinson's community, find out what they're doing, how they're managing, what they're doing. Don't do this alone. If seek friends who've done this before, the community. If you're looking at places or if you're calling to see about agencies, have someone who sits next to you if you want, who can come up with ideas of questions to ask. Have someone go with you. I mean, we talked about the practical and the emotional. We certainly can talk about the practical and meeting those kinds of needs. I feel like it's really imperative that they also get the support for the emotional. That intertwining that happens can be complex and it can make things harder. So support is really needed. And, I came across this line. I don't even know. I can't even tell you where I was doing some research, but avoid the burden of decision making in isolation. Couldn't say that any better. Avoid the burden of decision making in isolation. You want to reach out. Please reach out. You don't have to have that burden of making these decisions on your own. Let your senses be your guide when if you're visiting, if you're thinking about it, if you're meeting people coming into your home, people coming in and making plans for care outside the home, your eyes, your nose, your gut feelings about things. Take all that into consideration. Use your whole self when you're making these assessments. And sometimes if you're I recommend that when people are maybe looking outside of the home for care, I would ask the places that you're the communities, would there be a time when you would not be able to provide care for me? I have Parkinson's and I have some memory issues. Is there a time that this what I'm looking at might not fit, might not be the right match, because that can be a really wonderful guide for you to think about in terms of, oh, maybe this isn't something for me, or maybe they might say yes, but we'll talk to you about it, and maybe you'll purchase. It's just a working kind of conversation and communication. And I do want to say that nothing is perfect. The person, place, or timing of this, that's really about communication, whether you're hiring someone, whether you're looking at a place, it's the opportunity to communicate and to find out more. That the right choices may not always feel they're right, that these parallel roads that, the decision making, the practical and the emotional sometimes cancel each other out, can make it complicated. So doing the absolute right thing might not feel like the right thing. So that you can lean on all of us, your team, to help you with that. And then again, that idea of when will I know? Like if you're asking that question, if that question's coming up, when I think, I'm wondering if, I would follow that intuition and reach out to me, Giselle, Dr. Petrosian, American Parkinson's Disease Association, someone in the community to help you think through and talk through some of what you're seeing and feeling. And I think in general, what the next steps might be in terms of action steps, given that I've talked to you about a lot of things, I hope that you're taking care of yourself. Sometimes this is really anxiety provoking. The next steps would be absolutely to take a deep breath. You know, no decision needs to be made today. I've been given a lot of information. I hope that'll be helpful and at least begin the thought process. If you have questions, please reach out. That's an important action step. Talk with your spouse, family, your healthcare team. Communication is power. In fact, reaching out, knowledge is power. Communication, reaching out is your superpower. We're all here to help. And if you are caring for someone or you yourself are thinking about long-term care, think about it. Are you a veteran? Are you in the motion picture industry? Do you have long-term care insurances? Those are things that are available to help in terms of the financial resource of this, as well as other support services. So think about that. If you have these resources, now is the time to start exploring what do they have to offer me? I'm a vet. I'm entitled to. I'm someone who's in the motion picture industry. They have resources. I have long-term care. You might be a long-term member of a particular spiritual community, and they may have resources for their older community members, maybe care options. You want to explore just not only the usual, but may I say, the unusual suspects, things that you might not be thinking about. Talk with your financial advisors, talk with elder law attorneys. I'm happy to help and guide you, but these are the things that you'll want to start thinking about. And again, I can't say it better myself. Avoid the burden of this decision making in isolation. You don't have to do this alone. This is scary enough. You've been on the path. Many of you might be just thinking about this. This might be next steps. You're not alone. And it doesn't have to be another point of burden for you. So we're here for you. So I also I'll leave you with just talking about just some resources. There are professionals who have professional placement services there that are in the community that can happy to talk to you about everything in this area. If anybody's seeing this on YouTube and you're looking at and you're in a different area, a different state, there are resources for you as well, and they can talk to you about knowing all the availability from independent, assisted, memory care, these aging in place and community care communities are absolutely available. I gave some resources for the licensing. So you can have that because that's another good place to take a look and see what's available. And again, there are watchdog agencies out there. I mean, we're as a community really want to make sure that any care at any level that people are safe. And so the California Long Care Ombudsman is a program for that. And I think that's important when we're talking about different levels of care to know that we have your back. And then, of course, the American Parkinson's Disease Association. With that, I will end. I think I might be a little tad bit over, but I don't know if we have time for questions. If anybody has questions, or I'm completely available if anybody like to meet with one-on-one or to send this PowerPoint out to be a resource for you. So I thank you for your kind attention.
Sheila, thank you very much. I will say we obviously talk about everything in relation to Parkinson's in this webinars. and the medical side, but it is really this practical side that I think can be deeply helpful for patients and those um, family members that are caring for Parkinson's disease patients. So thank you so much. That was such a rich presentation. Really great to be able to just even the definitions of what those different levels of care is can be truly helpful for our patients. So thank you so much. We're really over time and we do not have any questions in the chat or in the Q&A anyway. So for those that are still in the call, in the webinar, if you have any questions, feel free to reach out to Sheila. Sheila is a part of our team and a lot of you already know her. So please reach out. But thank you so much for your attention. Thank you so much for being here. If you want to rewatch this presentation, it will be up in a few weeks at the PNI website. Thank you very much, Sheila. Thank you very much. And thank you
Thanks,
everyone
Giselle.
for being
Thanks for
here
asking.
today. Take care. Have a
Bye-bye.
great week. Bye bye.
Bye-bye.